Good morning, everybody. Welcome to Halloween Pediatric Grand Rounds. And now I have the pleasure of introducing our speaker for today. Kate McDuffie is a licensed clinical psychologist and assistant professor in the Truman Catt Center for Pediatric Bioethics and Palliative Care at Seattle Children's Research Institute and in the Division of Bioethics and Palliative Care here at University of Washington. Dr. McDuffie's research uses a combination of quantitative and qualitative methods to understand how advances in biomedical research impact children with neurodevelopmental disabilities, their families, and service systems. We're so excited to have you. Welcome, Dr. McDuffie.
Great. Good morning, everyone. Happy Halloween. Good to see everyone. Thanks to those who are here in person. Thanks to those who are joining online. So I'm Kate McDuffie. As mentioned, I'm an assistant professor at the Truman Catt Center, clinical psychologist and a bioethicist. And today, the title of my talk is, Should We Predict Neurodevelopmental Disorders Before Symptoms? So as humans, we've long been obsessed with predicting the future using archaic technologies like the magic 8-ball. For those of you who might not be able to see me online, I am a magic 8-ball for Halloween today. But crystal balls, tarot cards, more complex ways of modeling weather systems, machine learning-based prediction, all of these are techniques that we've really long desired to have in our back pocket. I think there's lots of us who might want to predict what's going to happen next week on Tuesday, for example. And so sort of capitalizing on this natural human tendency, I'm going to talk to you today about two emerging technologies that are being developed and implemented for predicting neurodevelopmental disorders prior to symptoms. As a bioethicist, my research is focused on understanding the ethical and social implications of emerging technologies in biomedical research and in clinical care. And for the past 6 years or so, I've been really interested in these kinds of technologies that are being developed and implemented for predicting neurodevelopmental disorders in very early childhood, really before the onset of symptoms. So I'm going to talk today with you all about two such technologies. The first being eye tracking for prediction of autism spectrum disorder, and the second, whole genome sequencing for predicting neurodevelopmental disorders. So here's a brief roadmap for today. First, I'm going to briefly introduce these two technologies. I'm going to use these two different colors and two different icons for talking about each technology. So if you zone out for a minute and need a reminder about which we're talking about, that's your cue. After introducing these technologies, I'll move into presenting some empirical bioethics data collected by my team and others on parent attitudes towards these new technologies. Then I'll discuss these findings in light of some relevant bioethics concepts that really arise from the literature, some of which have been around for quite a long time, that I think can link data about these emerging technologies to some age-old questions like, what does it mean to be a good parent? What's the meaning of a diagnosis for navigating the healthcare system? And what's the power of parental expectations? Then I'll conclude with a discussion of where we might go from here. My hope is that you'll walk away from today, maybe not with a clear yes or no answer, despite the promise of my costume, but instead with a deeper understanding of the complexities raised by some of these technologies and hopefully some suggested reading if you want to dive a little deeper. Okay, so we'll start with eye tracking for autism spectrum disorder. So this is a typical timeline for an autism diagnosis. Most children can be diagnosed by around age 2, with a bit of a tail in either direction. However, the average age of this country remains not until around age 5. The AAP recommends screening for autism using instruments like the MCHAT at 18 and 24-month well-child visits, but this hasn't been implemented consistently, and it really hasn't yet moved the needle on actually reducing that age of diagnosis and moving it younger than 5, for a whole bunch of reasons, which I'm not going to fully go into today. We do know that early intervention begun soon after diagnosis can improve child outcomes. But for most children, there's this really long gap between the average age of first parental concern, which tends to be around 12 months, and then when the diagnosis eventually happens. This is called the diagnostic odyssey, a term I'm sure we're all quite familiar with, and is a time when families are really struggling to figure out what's going on and what to do about it, and they're spending all their time doing that rather than actually receiving the evidence-based interventions that could make a real impact. So there's great interest in really preventing that diagnostic odyssey by doing biomarker-based prediction in the first year of life, so that by 6 months or a year, you could accurately predict which infants will go on to develop autism by age 2 or 3, thus preventing that diagnostic odyssey. So there's a lot of different tools that are being developed to predict autism in the first 12 or 18 months of life. Neuroimaging technologies like MRI or EEG. There's naturalistic eye tracking, digital phenotyping, which is where a child interacts with an iPad app and their behavior is measured. Computer vision, which includes coding of video interactions, capturing social interactions. Even things like AI-based analysis of electronic health record data. All of this has been shown initial efficacy, and the citations are here, for predicting a clinically validated autism diagnosis by age 2 or 3. So I'm going to focus today on one of these technologies, eye tracking, although a lot of the concepts, as you'll see, don't really depend on the specific technology. We're more thinking about what's the ethical implications of predicting something early rather than the specific idiosyncrasies of one technology or another. Part of why I want to focus on this naturalistic eye tracking is because there's actually an FDA-approved device now for using eye tracking to predict autism. So this is a company called Early Tech Diagnostic. These are screenshots from their website. They're founded by researchers at Emory who developed what they call Early Point, which is the first FDA-approved age tracking device for detecting autism in very young children. Early Point is a small iPad-sized device which plays videos of social interactions of preschool-aged children and that monitors the looking behavior of the child who's seated in front of it. Last year, Early Point was approved for use in children as young as 16 months, but it's currently being tested in an R01 in children as young as 9 months. So a little bit more detail about how it works. You can see here some screenshots of the kinds of videos that children watch on Early Point. And the heat maps there show the age expected areas of fixation for typically developing children. Then you can see the fixation circles of individual patients with autism. 4 different patients are shown there. And then zoomed in, you can just see the content of what those children are looking at. And you can see it's things in the background, particularly sort of interesting visual patterns, bold colors, things like that. But not, importantly, the social stimuli, which is what typically developing children tend to focus on. So this team from Emory and Early Point, they've been doing this research for decades. They have a really well-tuned algorithm where they take the data from this eye tracking, and they are able to spit out what they're calling Early Point severity indices that tell you where a child is likely to fall in terms of social disability, verbal ability, and nonverbal learning. The idea then is that this isn't an autism diagnosis in and of itself, but is intended to guide clinicians and, in combination with clinical decision-making, lead to an autism diagnosis. So again, this has so far been proven in children as young as 16 months, but is being tested in children as young as 9 months. These are 2 studies that came out in JAMA and JAMA Network Open last year with just a bit more of the details for those of you who really track these things about sensitivity and specificity of this eye tracking tool. These were 2 different samples, one with children recruited from specialty clinics, so who already had concerns for autism. The second study was a bit broader with over 1,000 children in a discovery and a replication cohort. And that study recruited both from specialty clinics and from primary care clinics. Importantly, so far, this technology hasn't been used really as a screening tool. It's been more used for children who already there is some concern for autism. So it's a little bit unclear how it would perform in a truly general population type sample. But that's the kind of thing that the researchers are now working on. Okay, so in theory, a device like Early Point, or maybe some of these other technologies, if they catch up and also get FDA approval soon, is to have a predictive measure in place so that you could predict a subsequent autism diagnosis maybe around 6-12 months, and that children could then be connected early with these evidence-based, very early interventions to improve outcomes. Of course, it's more complicated than that, and I don't have time to go into all the details of this today, but if you're interested in this topic, this is an ethics rounds paper in Pediatrics that we published a few years ago that tackled this issue from a few different perspectives, from child and adolescent psychiatry, clinical and educational psychology, and autism self-advocacy, and bioethics. So lots of interesting issues to debate there. Okay, so shifting now to our second technology, whole genome sequencing for neurodevelopmental disorders. So I'm sure most of you have heard about whole genome sequencing. Very basically, it's a technique that sequences an individual's entire genome, including protein coding and non-coding regions. It enables testing for a wide range of variant types, like SNPs and CMVs, in a large number of genes simultaneously. So that gives it an improvement over other types of DNA testing methods that might only look for one type of variant at a time. Whole genome sequencing is usually guided by a panel of genes. So even though all of the genome is sequenced, only those genes known to be associated with specific clinical features of interest are analyzed. And so that's an important feature because what those sort of genes of interests are can change over time, as we'll talk about even maybe within a single study, adding another layer of complexity around what can you actually really learn from this, and how can that change over time. So there's lots of ways that whole genome sequencing is being applied in medicine, but the specific context that I want to focus on today is the idea of newborn genomic sequencing. So this is different from newborn screening, but I'm going to anchor it in newborn screening because I think that's a helpful place to start. Newborn screening, as I'm sure you all know, is a public health program that screens for treatable rare diseases within the first hours or days of birth. It's a heel prick test where a series of blood spots are collected, and then they are sent off to state laboratories where a number of conditions are screened for. Each U.S. state participates. The federal government has a list of recommended conditions, the Recommended Uniform Screening Panel, or RUSP. States aren't required to test for all the conditions on the RUSP, but many do. And the RUSP contains 35 core conditions and 26 secondary conditions, and some examples of the kinds of conditions screened for are shown here. The idea with newborn screening is these are really supposed to be disorders that are immediately treatable, that if not treatable would constitute a medical emergency. And so the idea of capturing this information very soon after birth can allow for immediate intervention and prevent morbidity and even mortality. So these tend to be opt-out programs. The assumption is all parents will do it. The nuances differ a little bit by state. But again, as a public health program, the idea is that this is really should be mandatory and all parents should participate in this. Okay, newborn sequencing then has the potential to use those same dried blood spots that are connected through newborn screening, then apply whole genome sequencing technology on them to screen for hundreds or thousands of conditions. In the US, this is not currently happening, but there's murmurs that it might someday. And there are other countries like the UK, Greece, Qatar that are moving forward with full sort of countrywide public health pilots of newborn sequencing. So just to talk a little bit more about that, this is a figure from a preprint that's in medRxiv right now that's showing 27 newborn sequencing programs that are happening around the world. The research studies are indicated with little triangles. The plus signs indicate commercial efforts. Just note that there's an equal number of commercial and research efforts in the US, so there is a lot of money in this space and a lot of commercial interest in it. So these programs vary quite a bit in terms of the numbers of genes analyzed. So the number of genes included on that panel range from 134 to 4,300. Interestingly, only 74 genes are included in over 80% of the programs. So there's quite a bit of variability across these different programs in terms of what genes are screened for. Some of that may have to do with idiosyncrasies of the population, but it also is largely driven by different criteria that these different programs decide that they want for genes to be included on their list, like how treatable it is, whether it's child or adult onset, things like that. So let me give you one sort of dive into a specific research study. This is a Guardian study. It's being conducted in New York City. The funders and partners are shown there. Wendy Chung is the PI of this project. So Guardian is interesting. It has 2 different groups of conditions that families can opt into. It's a research study, so it's opt-in. Group 1 conditions, it's about 350 conditions, they all are considered treatable. So they all have medications or interventions that prevent or lessen the symptoms of the condition. And so a few examples of the Group 1 conditions are shown there. So every family enrolled in Guardian gets sequenced for the Group 1 conditions. Then parents can choose if they also would like to be sequenced for Group 2 conditions. This is the language taken directly from the Guardian website, because I think it's important to hear how they're describing this to potential participants. So for Group 2 conditions, there are no medications to treat these conditions yet. Medications may be in development, although they don't know yet whether they will work. Many of these are neurodevelopmental disorders. They make mention that a child might benefit from early intervention. Some of them, it's not mentioned here, but are associated with seizures, and so the idea is you might be able to treat the seizures early if you knew that children had these disorders. So there's about 100 conditions in Group 2, and again, a few examples are shown there. So very conveniently for this talk, Guardian just published their first paper last week, so I'm able to share this with you. So this is just an initial interim analysis of the first 11 months of Guardian. I don't think I mentioned this. Their goal is to sequence 100,000 families. So in the first 11 months, they approached 5,555 families in New York City hospitals, and 4,000 consented. And these families are approached in the Healthy Newborn Nursery. It is a quite diverse sample, particularly in comparison to other large genome sequencing studies, which have been really not representative. They reported that 90% of families consented to both testing for Group 1 and Group 2 conditions, so both the sort of definitely treatable and not yet treatable set of conditions. And they had a screen positive rate of 3.7%. So 3.7% of the 4,000 children sequenced received some sort of positive result, including 11 Group 2 conditions. Okay, so similar to the autism example, I could give probably a whole semester talking about the unresolved challenges of whole genome sequencing and newborn sequencing. And I'm not going to talk about these in detail, but just to lay out a few, and then I'll give you some citations in a moment. So there is, of course, a risk of false positive or negative screens. One of the things that study like Guardian is doing is they're comparing their results to the state newborn screening, seeing where there's discordance and trying to figure out why. There's also, this is a risk that is much higher in populations that have been underrepresented in genome research to date, because they're not part of the sort of reference genome that's used to find these variants. And so the fact that this kind of technology could work only really for one population but result in many, many more misses for more underrepresented groups is a real concern and big equity concern. There's also issues related to incomplete penetrance and expressivity. So this describes the fact that just because a child has a variant, it doesn't necessarily mean they will develop disease, or doesn't really tell you how severe the disease presentation will be. This differs by condition in terms of how much an issue this is, but obviously from the perspective of a family really matters, because you want to know if this information you're getting is going to actually predict where your child might land in the future. I mentioned this a little bit earlier, but there's the possibility of reanalysis. So once you have the genome sequenced, you only look at this initial panel of genes, but later you could decide to reanalyze the data with new information. Let's say the child develops symptoms that maybe you weren't expecting. You could reanalyze the data with those symptoms in mind and potentially come up with a different result. Because you're looking in a different place that you didn't look before. And so this, again, is something that I think is really hard to really fully explain to families, and presents just a bunch of challenges around storing this massive amount of data, who does the reanalysis, who communicates these results in the future, et cetera, which leads to cost and workforce considerations. We know that we do not have enough genetic counselors already, and so how could you possibly train a workforce quickly enough to scale this up to the level of a public health type program? So a lot to be said here. Again, I'm not going to go into any of this in more detail here, But I will recommend these two different papers. One, if you're looking for a sort of a bullish account of newborn sequencing, but which I think does a good job of realistically describing the challenges, this paper by Stark and Scott. And then if you want a paper that from the title you can tell how the authors feel, Spodka and Ross, that is really sort of very much against newborn sequencing, particularly for neurodevelopmental disorders. Okay. So for this next section, we're going to talk about some empirical data on parent attitudes towards these two predictive technologies, eye tracking for autism, newborn sequencing for developmental disorders. Some of this is work done by my group, some is done by others. It's not meant to be an exhaustive overview, again, of every single potential bioethics concern here. And I think if you asked 5 different bioethicists to give this talk, you'd probably get 5 pretty different talks. But what I'm going to highlight here is the points that have really been sort of stickiest to me, that have really stuck in my mind, and that also maybe haven't received quite as much attention in the literature to date. So as I talk about some of this empirical data, I'm going to be pulling quotes and data from these 3 papers. The first was done by a super talented postdoc, Aurora Washington, in my group, on parent attitudes towards predictive testing for autism in the first year of life. And then I have 2 papers focused by other groups focused on parent attitudes towards newborn sequencing, one by Rebecca Moultrie and colleagues, and another by Sarah Ackerman and colleagues. Okay, so to think about parent attitudes towards predictive testing in autism, this is a very quick snapshot of Aurora's paper. But we did qualitative interviews with 55 parents of infants aged 6 to 13 months. So they were right in that age range where there's a lot of promise for this kind of pre-symptomatic prediction. 30 of these parents had an older child with autism. So they knew that their infant was at higher likelihood of developing autism because it does run in families. They also had prior experience with autism, sort of knew the service system. 25 of the parents had no other children with autism, and so didn't know as much about autism and were new to these questions about how the autism service system works. We asked in these interviews about predictive MRI for autism, because this project was done in collaboration with a research network that's developing predictive MRI tools. But the interview questions we asked really weren't specific to that technology. So again, you can, I think, pretty easily substitute eye tracking or some of these other technologies for predictive MRI, because we didn't go into the details of what the MRI would look like. We more took a broader view and asked parents to think about what it would mean to get this kind of information during this pre-symptomatic period. Okay, so we learned from our 55 parents, all but one said that they would be interested in this kind of predictive testing for autism between 6 and 12 months, particularly if they had any concerns about their children. A few said things like, well, if I wasn't concerned, I probably wouldn't go for an extra test. But if concerned, yes, I would absolutely be interested in that. And the primary motivation we heard from parents in both groups was to have more time to prepare, logistically, emotionally. As this first quote says, well, this is a parent with autism experience. With our older child, we got our diagnosis, and then we had to wait forever to get him in anything because of the wait list. So knowing sooner, I could help her get the resources and things to help her. So this is a parent that's familiar with the fact that even once you have an autism diagnosis in hand, you might have to be on a wait list for quite a long time. And so the idea of accelerating that, of getting on those lists sooner, really appealed. And the second quote really speaks to the emotional preparation. This parent put it, to have that moment to take it in, mourn a little bit. I hate to say mourn, but just have my feelings around it and then be like, okay, this is real, and then just jump on board with things. So we heard these themes over and over again from parents in this study. Okay, so switching to newborn sequencing. You might see some similar patterns here. Almost all parents in this one study, and there's many studies that have looked at this, 91% said they would definitely want newborn genomic sequencing if presented with the option. And similar themes came up. So as this first quote said, this parent said, they always say if you can find it early, they can fix it. If you wait till the last minute when it can't be helped or if it's too far gone, so you can find a way sooner than that, you might go ahead and cure it. So again, this idea, early intervention's better, let's get in early interventions as soon as possible. And then this second quote speaks more to some of the other sort of life preparations. As this parent put it, especially financially, start preparing with getting appropriate insurance. And I mean, especially for us, we're low income. So finding out something drastic would be like, okay, well, now we need to prepare ourselves with insurance. We need to prepare ourselves to treat our child. So very similar themes come up in these kinds of studies around parents seeing a lot of advantage to having this information early to be able to prepare. Okay, so we're good, right? Parents want this. So not quite. But thankfully, these were not just survey studies that asked a single question, do you want this technology or not? These were qualitative research studies. And so even though almost all or more than 90% of parents said they were interested, they said that in the context of full conversations. And so we can hear their much more sort of nuanced perspectives. So let's dive into that nuance a little bit. And as a way of framing this, I want to talk about this in relation to 4 risks, which are really, that have been articulated in the bioethics literature previously. I'm going to do in this section is sort of link the literature on some of these risks to some of the responses heard from parents in these studies. So I'm going to walk through each of these 4. And as I do, I hope you'll all also think about where some of these concepts might show up in your own clinical work and the patients that you work with, whether they have anything to do with these technologies or not. Because I think a lot of these themes are really pretty central to how we think about medicine and early childhood. And please share reflections during the Q&A if you have them. Okay, so this first concept is referred to as patience in waiting. And so the authors of this paper, Timmermans and Bookbinder, describe patience in waiting as inhabiting a liminal space between normalcy and pathology, imposed by medical screening and testing technologies aimed at secondary prevention, characterized by a lengthy process of medical surveillance to resolve diagnostic uncertainty, which may spill over into personal identity and other areas of life. So the idea would be by using either eye tracking or whole genome sequencing in the first year of life or so to identify a children likely to develop a neurodevelopmental disorder, you are creating a patient in waiting, and not just a patient, but a whole family in waiting, right? That lives in this liminal space between a healthy, typically developing child and a child who will develop delays, just nobody really knows when. And so a couple of quotes from the parents in these studies that I think reflects this notion. As this top quote said, this parent, I mean, just because if you think about it, when a family is told that their child has something, it changes your whole outlook on everything, because you're just more, the child won't get a normal childhood because you're going to be more cautious and more don't do that because something might happen. So describing this idea of a parent sort of being constantly vigilant and how that might impact the childhood experience of that kid. As this bottom quote from our autism study, if I was told she was going to get it, autism, and with each passing day she's not showing any signs, I would just continue to wait for it and continue to think that everything that shows up, it could possibly be chalked up to her autism. So again, this notion of waiting and looking and vigilance for symptoms and really thinking about how that might impact both parental anxiety, as I think comes through pretty clearly in these quotes, but also the first couple years of life are so critical for the parent-child relationship. And so I think a piece that is really hard to capture in a survey is how might information like this really interfere with that ability to form that critical bond or just impact that bond in those couple first years of life. Okay, the next concept I'd like to talk about is self-fulfilling prophecy. So this phrase was actually coined by Robert Merton in 1948. His definition is when a false definition of a situation evokes a new behavior, which makes the originally false conception come true. So put another way, an individual's expectation about themselves or about another person could eventually result in that person acting in ways that confirm the expectation, or engaging in behavior in ways that end up confirming the expectation. So again, to talk about 2 quotes that parents really brought up here, this top quote is a father reflecting on what he thought would be the meaning of a sort of pre-symptomatic diagnosis for his child. That it's psychological, it's very mental strain, it's stressful. You're going to stress yourself out, make your own self sick. So the idea that the child kind of knowing this knowledge could potentially exacerbate symptoms because they had this stress and worry about it coming. This second quote is from a parent in our autism study. They said, you don't just give up on his speech because you think that, oh, he's going to be low functioning. You don't give up on trying to help him in certain areas because you think he might not make progress. Don't limit him. So this is a notion that it's maybe not so much the psychological strain or worry, but the fact that you might actually approach seeking therapies and early developmental supports differently if you were told, think about that early point, the different severity indices. If you were told, your child's likely to be very, very severe in nonverbal and verbal learning, maybe that would change how you approach intervention. And then because your child's getting a different type or dose of intervention would ultimately impact outcomes. So this was, again, a quote that we didn't hear the word self-fulfilling prophecy necessarily come directly from parents, but this notion that by limiting expectations, it could impact how an individual sees themselves or how a therapist or treatment team really approaches intervention for these kids. The next concept is something called inflicted ought. And so as the authors, Anderson and colleagues describe this, they say, on the one hand, options provide choice, enhance freedom, and empower individuals to make decisions for themselves. On the other hand, optionality increases responsibility, and this can be perceived as a heavy burden. This term inflicted ought is meant to capture the sense of burden imposed by the choices on offer. So thinking about this in the context of you were to introduce a new technology like Early Point into a primary care visit or introduce sequencing as part of standard newborn screening, this is an additional option for parents. Empirical data suggests they say they want it. But is it increasing, is it providing this choice? Are you increasing this responsibility, this burden to sort of do everything, do all of the tests, get the information? There's a few quotes that from these studies that I think really speak to this. As this top one from a genome sequencing study, this mother said, making sure our kids are healthy, like taken care of. I don't know. That's probably the biggest, maybe the only thing. Like just make sure we're doing what we can as parents for their health. So given the option, given this additional screening tool, I think I should use it because that's what you do to keep your kids healthy. And this parent who didn't have any autism experience in our autism study said, oh, absolutely, we'd want this test because we're thinking of giving him the child. I think they're having COVID tests for babies about 6 months, so we're planning to have that as well. So yeah, we definitely want to try that out. So this parent just automatically looped it in with a COVID test. And that, you're getting tested for COVID and you're doing this and you're doing this. So of course you would also do this test for autism because that's just what you do as a good parent. So I think we see this a lot in medicine, right? This idea that once you add a new thing, it just becomes part of what you should do. I think this is the case often with non-invasive prenatal testing as well, even before a child is born. And it doesn't really leave a lot of space for families to really think about, do you really want this information? What might this information mean for you? And is this really a good decision for you and your family? And then the final concept that I want to talk about in this section is the notion of a therapeutic odyssey. So we talked about the diagnostic odyssey. We're all familiar with that. In this paper by Jeff Brosco, he describes most families and their children are not really on a diagnostic odyssey. They're on a therapeutic odyssey. They're on an odyssey to find what will help their child, not necessarily what's the label for their child. And as Brosco describes it, that odyssey is a search for anything that will help their child walk, talk, run, play, learn to read and write, and wonder and search for answers. And we saw this notion come up in the empirical research as well. This is a quote from the Ackerman et al. Paper where they talked, this was a parent who got a genetic diagnosis for their child, a slightly older child in this study. This parent said, even though I took the genetics papers to school, they didn't pay much attention to it. So to me, it would help so much for genetics if they're able to come and see, whoever can come and explain to special ed, even the school district, how important it is for the child to get that help. So this parent had the genetic diagnosis in hand, tried to take it to the school system to have it qualify their child for services, and faced this disconnect. The school system didn't find that information useful. It didn't automatically qualify for their services. And so in this kind of situation, what's the use of the diagnosis if it doesn't actually help a family connect? And you can hear this parent really calling for, I need help with this. I need someone to come and help me make sure that everybody understands this is what my child has, and that means they need this kind of help. And this bottom quote, this is a parent from the autism study, said, I mean, obviously you can't start applied behavior analysis at 6 months. This is a parent who already had experience with autism. But whatever it is you can, speech, or whatever it is that you can do ahead of time, I'd want that in place. And so this parent they don't even know exactly what you could start as young as 6 months, but they have this notion, well, there must be something, right? If you're doing this test, there must be something that you could start, some kind of therapy you could do. I don't know what that is, but we would want that in place. And I think that's pointing up this really interesting gap, which I didn't really describe much earlier, but that there really aren't autism-specific services for children as young as 6 months. And so you're giving families this kind of information, but they're left without a way that they can easily translate this diagnosis into the therapies that they need and want to support their child. So this particular challenge is sticky enough to me that I've written a grant to more directly address it. So this is a study that we're calling SERVICE, which stands for Supporting Early Receipt of Services for Infants and Children with Genetic Etiology. In this project, we're proposing to follow 4 cohorts of infants who received newborn genomic sequencing and received a diagnosis. And our intent really is to assess for these families what barriers and facilitators they've found in trying to receive developmental services. So we're specifically focused on early intervention, which is funded through the IDEA Part C, things like speech therapy, physical therapy, occupational therapy, provided to all children who qualify for them, but I think it's a really open question whether these diagnoses made in the first year of life for pre-symptomatic children will serve to qualify them in these systems that are a limited resource and may not be really set up to treat children in these categories. If you're interested in reading more, this is a paper that just came out also last week. Betty Cohen is a fantastic public health genetics PhD student who really did a lot of heavy lifting on this paper. And this is sort of laying out the plan for this grant proposal and some of the challenges that we see need to be addressed here. Okay. So that's most of the content. I want to move into discussion now and sort of wrapping up. But I just want to give a quick sidebar here on the limits of empirical bioethics research, the kind of research that I do day in and day out. And I just think it's important to keep these things in mind as you're thinking through some of the data, some of the parent responses. I've already given a plug for why I love qualitative research, but there's some limits that I think are important to keep in mind. So most frequently when you're doing a study like this, parent attitudes towards XYZ new technology, the most frequently used methods are parent self-report, whether that be surveys or qualitative interviews. As is typical in all research, only the most motivated or engaged parents, in this case, tend to participate in these kinds of studies, right? So you are missing people who maybe didn't have as good of experience, don't feel as engaged, don't really want to continue to talk with you about what their experience was like. They're going to probably drop out and not participate. These types of studies are vulnerable to either what's called the intention-action gap in psychology. So if you're talking about a prospective decision, parent X, would you do XYZ new type of screening for your child? There's lots of data in psychology that a parent or anybody can say, yes, they intend to do something, but then when actually given the choice, they do not do that. And so there are often big gaps that are found empirically between a person's stated intention and what they might actually, the decision they might actually make in the moment. So that's a limitation if you're asking about a prospective future decision. If you're asking people to think back about a decision that they have already made, then the vulnerability there is post hoc rationalization. So I made the right decision, and these are the reasons why it was right. And I think, one of the really big challenges here is that it can be very difficult to admit to ourselves, let alone a stranger researcher, that we regret a decision that we've made. And in fact, the fact that many people do this kind of post hoc rationalization of, it was a tough experience, but I'm glad I went through it, that's a very psychologically healthy thing to do. That's great that people tend to have that kind of ability to weave an experience into their narrative and say, it was difficult, we learned these things, it caused some stress in the moment, but ultimately we came out stronger, and I'm so happy we did it. And so I just say this not to say that you can't ever learn good things from these interviews. I think you absolutely can. But I think we have to keep in mind that it is really hard to actually elicit feelings of regret, maybe even because a person might not have them because they've sort of integrated an experience. It doesn't necessarily mean the experience was good for them to have in the first place. Please challenge me on these points during the Q&A if you disagree. So, should we listen to parents? Of course we should listen to parents. Of course we should do this type of research where we engage and try to understand what families think and what they think is right for them. I think what we have to really balance here is the risk of, paternalism, of saying we know what's best for you, and so we're not going to offer you this option because we don't think it's right for you. Versus, I think the real possibility that if you just sort of roll out all these technologies, that there could be potential iatrogenic harm. And even if a family says ahead of time, oh, I would want this, they still might be harmed from the experience. And are they to blame for that? Are we to blame for that? I think there's just a lot of really careful thinking that needs to go into some of these decisions about how to implement these technologies. And some limits, I think, to the ways that we currently try to collect this data. Okay, so where do we go from here? I don't know if you all have been hearing this phrase everywhere these days, but I feel like it's coming up all the time. We're building the plane as we're flying it. And I think that's fine if you're, maybe you're figuring out a new administrative process as you're also running a program, and you're building the plane as you're flying it, and it's sort of fun, and you're learning on the go, and that's great. But what about with these new predictive technologies? Because I've heard this phrase used to describe these technologies as well. Like, oh, newborn sequencing, well, we're just building the plane as we're flying it. But there are people who are in that plane, right? There are families that are in that plane that are being impacted by these technologies that we're still really figuring out what they can do. And I think with these predictive technologies, it's like we're figuring out whether or not they're a good idea as we are deploying them. And that is a concern to me. But that leads into the question, is there another way to do it? I mean, obviously, you need to test these technologies in order to really understand their limits, understand their benefits and harms. And as I've mentioned, there's limits to asking people to consider a hypothetical scenario. So there is value in sort of testing these things in the real world and seeing how they work. But I think what really concerns me is when there are factors that sort of accelerate the move from research, which is really the space for learning about how these technologies work, into implementation, maybe a little faster than they should be otherwise. Factors like market opportunities for companies that stand to make a bunch of money from employment of these new technologies, for example. And these kinds of forces that, again, push us more towards implementation, towards deployment, before the full evidence of benefits and harms has really been gathered. And I see this happening in both the autism prediction space and the newborn sequencing settings that I've described today. Sort of like if you look and see that there's a whole bunch of startups in a whole area, that's maybe a reason to pause and think, okay, why do we feel like there's such a market opportunity here? Why is there so much push towards getting this kind of tool out? And where do we really need to be careful and make sure that the really strong research is being done to properly evaluate these technologies before they move out to the market? Okay, so how to proceed? I think one way that I've found useful to think about this, it's potentially useful, but it's maybe also overly simplistic, so please feel free to push back, is to really think to yourself or really think about one of these specific applications and consider what is the goal of this project. Is the goal to do research? If so, in research, the intent is to produce generalizable knowledge. And so you can structure how you roll out a tool, how you study it, what kind of follow-up you do, et cetera, keeping grounded in that knowledge that what you want to do in a research study is produce generalizable knowledge. The goal in a research study is not necessarily to benefit an individual participant. There might be the prospect of direct benefit, but there's also the possibility of risk. And people who enter into research studies, at least ideally, are fully aware of those and accept those possible risks as part of entering into that research. That context is very different from clinical care, where the goal is to improve the health of an individual patient. And because we all work with children, we know that the patient is never just an individual, but the patient and their entire family. And so that might be a sort of different way of thinking about it, because you really want to avoid harm for your individual patient. You really want to promote benefit for them. And so that might lead to a different way of thinking about how you employ a given technology. And then the third bucket is public health. So the goal for public health really is to improve the health of the entire population. So this is a high bar. You have to be able to prove that the benefits must outweigh the harms at the population level. And that is then taking into account all of the constraints of the resources that exist in the real world. This isn't the perfectly controlled setting of research study. This is the real world with limited resources. And so accounting for all of that, does it make sense to roll out this technology? Will it improve health of the overall population? So I think keeping this in mind, which of these sort of three pillars are we operating in, can help with navigating, in my mind at least, some of these challenges and thinking about how to employ some of these emerging technologies. But again, really interested in hearing from what you all think. Pushing back is definitely welcome. And yeah, would love to hear from you. So to close, I just want to thank so many people. I wanted to keep going in multiple more slides, but I tried to squeeze it onto one. So my pediatric neuroethics lab, my fantastic team, long list of collaborators and mentors, my funding, that's my email. Please feel free to contact me. And here's the link to the evaluation. Thanks all so much.
I'm curious if you could talk a little bit more about the ethical risks from the perspective of the child. You know, several thousand infants in New York have now given their genetic material to a commercial entity, and who knows what will happen with that material over the next few decades and how those children will feel about it when they're adults. Did the parents express worries about that? Do you have worries about that? What are the risks for the children themselves, especially the children who turn out not to be potential patients, but to screen negative?
Yeah. That's a great question, and a big question mark in terms of if you were to roll out newborn sequencing on a broader scale, where would all that data go? How long would it be kept? Who would have access to it? I did sort of gloss over the child's interest in this presentation because it tends to be glossed over because they're newborns, but I don't think that that's necessarily fair. I mean, obviously, a newborn doesn't have a decision about whether to participate in this kind of research at all, but they someday will. And in some of the genetic study, particularly those that are talking about sequencing for older kids, parents do talk about that, about what would it mean for, you know, an older child to know that they're likely to develop some kind of condition. Is it really right for me to make that decision and to access that information for them, or should it be really their choice when they turn 18? And that tends to be why screening for adult onset conditions is not recommended in childhood. But some of these studies, these sequencing studies, do include adult onset conditions. So, you know, there is, I think, a bit of a move towards, well, maybe some of the adult onset conditions we should include here. And I think it's really critical to keep that in mind about, is that information the child should really seek on their own when they're ready, or is it the parent's place to do it?
Kate, that was, I agree, fantastic. On your last slide, I appreciated that framing, but I was always in the public health lens when I was listening to you from the beginning, in part because of your sort of stating the intent of where these technologies are heading. The intent is to screen the general population so we can understand who is likely to have autism, so that we can move the delayed diagnosis back so that we can improve outcomes, for instance. And because I had that public health lens, I couldn't get Wilson and Younger's criteria for screening out of my head, and how we've departed from those, really, particularly in the genomic era, as you know, and justifying departure from that based on, well, it's a good in and of itself to understand better the prevalence of some of these diseases and the natural history of these diseases, so that we can learn more and eventually be able to develop treatments for them, even though we're screening for them now and don't have necessarily treatments. I mean, the newborn screening program and diseases in newborn screening, not sequencing, more and more don't have treatments for them, and so are being justified to be included in that just because of that new argument. But your work is really at this intersection and the tension between these classic criteria that have long been argued need to be in place for ethical and equitable screening that we've departed from, but yet there's reasons for that tension. So I'd love to hear from you. Have we departed too far from that, given what you're finding with your data? And should we be returning more towards these classic criteria and ensuring they're in place so that we don't get into these places where we don't have treatment facilities to provide access to treatments for those that are detected with undetectable diseases?
Yeah, this is so important. And I think why I've wanted to separate these into buckets is because I want them to be cleaner buckets than they are. They're really not. I think that, okay, so somebody like Wendy Chung, who's running this study of 100,000 newborns in New York City, I think she would say, this is not a public health effort. This is a research study. And you need to screen 100,000 babies because these conditions are so rare. But it's not until we find them that we would be able to have enough to run a treatment study to develop a treatment. So the idea that we need to do these really, really large-scale research studies in order to identify a population to develop treatments, I think a lot of people are comfortable saying that lives in the research space. That isn't yet, we're not yet moving that to public health newborn screening. It's not until you actually get to the point that you have developed a treatment and shown that it works that then it's implemented in public health newborn screening. So I think that's how some people think about it. But again, there's other countries that are already moving forward with newborn sequencing at the public health level. And so I think this is an area in which those lines blur a lot. And then it does make you question, what is the intent of this program? Is it to create generalizable knowledge in a public health program? That's not typically how we think about public health efforts. So yeah, I think the blurring is happening and it's a big concern. And I was just at this meeting, the International Conference on Newborn Sequencing, where all 27 of these programs were there. And this is something that is sort of fought over at this conference every year, is what are we doing? Are we doing research? Are we doing public health? And there's not consensus.
Kate, this was great. I guess to sort of think of the other end of that spectrum, help me understand, why isn't there a fourth bucket of direct-to-consumer because parents want this, akin to 23andMe or something along those lines, another direct-to-consumer genetics company? I'm not suggesting this is a positive example, but just in terms of kind of filling out your figure.
Yeah. No, that's a really good point. That there is absolutely that fourth bucket and groups that are moving towards direct-to-consumer. And actually in both of these spaces, in the autism prediction as well as the newborn sequencing space, I think I didn't put it on there because I feel like as a bioethicist, both underinformed and unable to influence anything that's happening there, right? It's hard. These are private companies. They don't share data. They don't share information about what they're really doing. You can go on their website and try to figure it out. And I, again, feel like I do not have any ability to influence sort of policy in that space. So I've left it off. But I think it is important to acknowledge that that also is there and that there might be sort of more and more efforts to move in that space with this idea that, yes, you're empowering families and you're giving them what they want, and you're increasing the market if you are able to sort of go directly to families.
Thanks for the talk. I really appreciate your perspective. And I just wanted to ask you a question about flying the plane while building it.
Yeah.
So as a clinician, I practice very differently now than I did 28 years ago when I started in practice because there are new technologies and it's natural to be a little bit hesitant to implement new technologies. It's great to have you on board guiding us. Sometimes we go off course. But I struggle to come up with an example where we crashed. Can you give me an example where the new technology really was implemented so poorly that it was a crash, as opposed to having somebody who just needed to be guided in a different direction?
Off the top of my head, I don't have one that immediately comes to mind, but I'm curious if anyone in the audience wants to chime in with one. I think it's an interesting notion, though, because it's sort of, does it have to be a total crash for there to have been people who were sort of collateral damage in the process? And that's maybe a harsh way of putting it. But I think I worry about the people who maybe didn't crash and die, but who were injured, as we were figuring out this system, and that, particularly if they are newborns, right, that might be something that is with them for the rest of their lives. And again, we can't wait until we have absolutely perfect data for every single thing before we roll it out, because it's just too slow. So I'm not saying that's the way that we need to go here. It's more just, I think the flipness of that particular expression gets under my skin a little bit, because I think we don't think enough about the people who might be harmed or injured in the process. Yeah.
Incubators.
I figured my colleagues would have examples. Thanks.
Thank you so much for that presentation. It was really interesting. I'm a special education teacher here at the hospital,
Cool.
so definitely not in the medical realm necessarily. But the comment that one of the parents made in your slideshow in regards to support at school, as far as special education services, really struck me. This predictive genetic testing could have pretty huge implications in regards to how schools respond to this data and this testing, and can really determine the track that kids are put on in their entire school career, in their throughout their entire life. And I'm just curious what sort of work is being done in addition to this research on this genetic testing, as far as like what it would impact outside of this, like as far as school goes and as far as their life moving forward. What kind of education is being provided to school teams and to parents in regards to what can or can't be done, as far as the support that they're going to get at schools?
Yeah, that's such a great question. So this project is a first step in that we are focusing on the early intervention system for kids under 3 before they transition into school-based services. Our plan is to both interview parents about their experiences accessing or failing to access early intervention, but also their early intervention therapists themselves, to learn from the physical speech OT therapists, did the genetic diagnosis help you in terms of guiding your treatment decisions for this kid? How did you use it? If you were looking up information about the diagnosis, where did you go, right? Because genetics training is not typically part of their education. So we're really interested in learning about that. And then, my wish is that we get not only this first grant, but then we get a second grant to follow up those same kids as they transition into the school system. Colleagues Kyle Brothers and Aaron Goldenberg do have a study right now of school-aged children where they're interviewing special education teachers, speech, physical therapists in the school system in a similar way to find out, the fact that this kid came in with this genetic diagnosis, did that impact what you were working on? How did you sort of track that kid in your mind because of this information? So we're really actively trying to learn about that, because you're right, it is absolutely not factored into any of these questions about clinical utility for these tests. Those questions are very much focused on medical interventions only. But they leave out the fact that eventually this child goes home and is in the community trying to get services, and are they able to use this diagnosis usefully or not? Yeah, thanks for that.
Hi, thanks so much for this talk. I was thinking about the different buckets you were talking about, and I know that often people will argue that the general knowledge research piece can bridge to public health through advocacy and through policy making, and I know that's easier just like said than done, but I'm wondering if there's any things you've seen that like your research or other similar research has been used both like at the national policy making level, and I know you said you feel like you don't have much insider influence into all the private companies working on this, but I'm assuming hopefully there's some regulatory body somewhere that has some influence, and I'm wondering if there are any bridges between like this ethics work to kind of those types of committees, and also advocacy for more services, given we might be identifying more kids who will need them. So I think whether you're involved or if you know of what that involvement looks like currently.
Yeah, Thank you for that. Please come to my grant review and please make that pitch to the grant reviewers, because that's exactly my hope for a study like this. Our early intervention system is chronically underfunded. And if we are about to really increase the number of children identified pre-symptomatically who are in need of these kinds of services, but we don't increase the funding that goes to states to provide that, we're just going to increase the inequities that already exist. So I think there's a lot of work to do in the policy advocacy space related to early intervention. Just to go to your point about sort of how research and advocacy impacts public health, there is a big role for parent advocates in advocating to get new conditions on the recommended uniform screening panel. And I think a very influential argument, one I always find quite compelling, is when a parent at a talk like this stands up and says, listen, if my kid hadn't gotten this diagnosis, and if many more kids weren't getting this kind of screening, we never would have been able to form a community, to advocate to get on the RUSP, to form a foundation, to fund medical research, to get treatments. And that is really true. And there are heroic parent advocates that are working to get their child's condition on these panels. And I think having their voice in this discussion and their incredible efforts is really, really valuable. So that's, I think, another space of sort of getting to influence which conditions are on that public health newborn screening panel. And then an interest of mine is then can we get that list to correspond to list of automatic eligibility for who gets into early intervention? Because if you had, every kid that gets this kind of diagnosis in newborn screening also gets access immediately to the kinds of early intervention supports they need, I think that would be a much more seamless system that didn't require so much fighting for each individual parent.
Wow, what a wonderful presentation and so much to think about. Thank you so much for your time, Dr. McDuffie.
Thanks.
And to everyone who's here, both in person and online, we'll see you all next week. Thank you.
Thank you,
Happy
everybody.
Halloween.